Um, Hello, can you all hear me? Hello, Seba, can you hear me?
Yes, yes, Dr. Joseph, I can hear you.
I think we should start this time.
Okay, doctor. So, good evening, everyone.
Good evening, Seba.
I hope you can all hear me.
Very well.
So, welcome to our usual Sunday Afro DX Clinical Unknown. Today, I'll be presenting an interesting case to Dr. Joseph. I'll be presenting a 48 years old male who presented with fatigue for 7 months. Then later on, he had joint pain for 5 months. Then skin darkening for 5 months.
Thank you very much, Seba, for that introduction, for taking your time from your busy schedule as a resident and presenting this case. Um, Pretty common complaints here, and approach them depending on which one will be of high yield. If we say fatigue, pretty much non-specific. Uh, if you've seen a sit in a clinic, I'm sure that one day someone came and said, "I feel fatigue," and you do everything and there is nothing. But first things first, in a patient who says that they have fatigue, like 7 months, so long, 7 months of chronic illness, like they have fatigue for 7 months. What you do here is, first of all, major organ failure. Patient with major organ failure, they usually complain with fatigue. If you want to check, just one day, you walk in a dialysis center and ask the patient, they will tell you they're usually fatigued all the time. So we're talking about kidney, heart, and liver here. All these patients usually have fatigue, but blood is also assisting. Patient with anemia will also be fatigued at most of the time. They'll feel fatigue, and even at clinic, people will say they have fatigue. What I do, among checking other things, I also do CBC plus ferritin. You find that they have iron deficiency anemia. Give them iron, it goes away. Other organs, also endocrine organs, especially thyroid diseases. People with hypothyroidism also complain of fatigue, but otherwise non-specific. And other patient will say fatigue, but what they mean is they have weakness. They have weakness, and it can even be truly neurological weakness. They feel tired because they are weak. So pretty non-specific, not high yield in this case, unless we know now what's causing the fatigue in this patient. But the next two, these are very important: joint pain and rash. So when you see joint pain as a complaint, the most important things are just two, is to say how many joints are involved, and then if the pain is of an inflammatory process or non-inflammatory process. What I mean here is number of joints. We have monoarticular processes. Think of an osteoarthritis of a knee. We have polyarticular processes like rheumatoid arthritis. You have many joints involved. But again, you have an in between process, which is usually pretty non-specific things. You can sit on one side or another. And then to say an inflammatory process or not, you know of the things that will be telling of a joint process to be inflammatory or not. Things like erythema of the joint, warmth, like you touch two joints, you touch the joint, you feel it's warmer compared to the other, and joint swelling. So we'll be interested to hear of those things in history and the exam findings. Rash, which is skin darkening. Also, for me, when I see a patient with a rash, I ask myself, is the cause of the rash more likely to be a disease arising from inside the body, or is something coming outside and causing the rash? If I wear a watch on my wrist and on the next day I have an itchy rash on my wrist, I understand that's an outside process, a watch causing dermatitis, atopic dermatitis on my skin. But there are processes coming from inside. Usually, these processes will turn out to be bilateral. Like you see the rash on one side of the body plus the other. You say this is a process from inside. So at the end of the day, I understand this problem. The root of this case will be to come up with something which connects a rash, joint pain, and this thing which causes fatigue, which we'll find out is this anemia or what, kidney failure or something else. So let me end up here and we hear the HPI so that we can continue the discussion. Thank you very much, Seba.
So thank you, Dr. Joseph. So the fatigue was of gradual onset, marked more on exertion. So the patient reports that it was persistent and progressive, worsening with time. So at some particular points, the patient reported difficulties in performing his daily activities. And he reported there was no significant improvement upon resting. So this was associated with nausea, loss of appetite, dizziness on standing, reporting some stuttering and almost near fall, and some few times reporting to fall from standing or sitting position. So he also reported increasing craving for salty food, with preferring of added salt in comparison to the previous time before the onset of this illness. There is also reported excessive sleeping during the day that was not present before the onset of the disease. So the patient also reported an intentional weight loss with reported almost 7 kilograms that were lost, which accounts for about 9.5% of the body weight in comparison to the premorbid body weight. So this was not associated with any anterior neck swelling, cold or heat intolerance, loss of libido, muscle pain, numbness involving the limbs, abdominal pain, abdominal distension, vomiting, constipation or diarrhea, passage of black tarry stool, or yellowish coloration of the eyes. So the joint pain developed 2 months after the patient started noticing the significant fatigue. So this was reported to be gradual on onset, non-migratory, and dull aching. So with the pain score ranging from mild to moderate, in terms of the number accuracy was about reported to be about 4/10. So it was symmetrical, started on the knees, then later on the hips, then shoulders were involved, sparing the smaller joints. So this was persistent throughout the day, and it was more marked on movement, and it was relieved by taking medications like paracetamol and other NSAIDs like ibuprofen and the likes. So the joint pain was not associated with joint stiffness, joint swelling, or joint deformity. Then later on, the patient reported skin darkening, which was gradual onset. So it was first noticed on the face, then palms, then later on both feet. It reported to be persistent, increasing with time. So It was not aggravated by sun exposure, and the patient reports no change in terms of the skin care routine or using any skin breaching agents. This was not associated with itching, any rashes or skin tightening, color change on cold exposure, or hair loss. There is no known open tuberculosis contact history. Patient has no history of prior hypertension or diabetes mellitus. There is no family member with similar presentation. The patient is a lifetime non-smoker and does not take alcohol. So previously, before the onset of the illness, patient had never tested for HIV, nor being vaccinated for hepatitis B. So he does not have any prior history of urethral discharge or having a penile painless ulcer. No prior history of multiple sexual partners or intravenous drug use. There is no reported history of blood transfusion or prior surgery in the head or elsewhere, and there is no previous history of radiation exposure. There is not any history of chronic medications use or any recurrent fungal infection which necessitated him to use any antifungal medications, and there was not any prior history of working in the mining industries or any area that he reported to have a significant chemical exposure. So review of other system was unremarkable. So that was the history, Dr. Joseph.
Thank you very much, Seba. This is quite an interesting case. Somewhat hard, but good to dissect because a lot of problems. And at the end of the day, maybe I can try to come up with something that can link all these. So yeah, we started with the bigger picture initially, and now we are having everything that was talked about in the chief complaint being dissected in bit by bit. So fatigue in this case is very important. As you have seen, it's associated with other stuff. It's not that the fatigue which patient says, and then if you pin down the patient, ask about fatigue, you find out there is nothing else. But here there are things. For example, patient has nausea and loss of appetite. And then when we hear they've lost weight, we are not surprised. If you are having loss of appetite, you won't be feeding enough, so you lose weight, even if your activity level remains the same. Um, Also, nausea and loss of appetite can also be a presentation of end stage renal failure, and we said one of the major organ failures can be presenting with fatigue, but that is not the case. If you think of this case, if you start at that point, you will lose your sight because it will be so hard to explain other things. Also, this patient has what Seba is telling us, like if they stand, they feel dizzy, orthostasis. So when you have orthostasis, it's a problem on its own and needs further dissection. Maybe it can lead us somewhere. So when you stand and feel dizzy, uh, like you feel like you want to fall down, which we call orthostasis, usually not much of the things. One is maybe your volume depleted, like uh, maybe you if you've ever gone maybe to a marathon, you ran a lot, you didn't drink water, and after you rest for some time, you rise, you feel like you want to fall. So volume down, but you be volume down for 7 months? Less likely. And other things, if the system to counteract the process, like when you stand, the neural circuits have to change itself in some way, increase the tone of your vessels so that blood can flow normal to your brain. So if you also have neuropathy of some sort, like peripheral neuropathy, which affect the autonomic nervous system, you can also have stasis. But this also stasis of this patient is surprisingly, because it comes with something that I've never thought of until this data set is telling us patient is having craving for salty foods. I know craving for other things like non-food material in patients anemia, but craving for salty foods, I've never thought of this thing. But if I use just my mind to say, why is the patient craving salty food? Are they hyponatremic? A patient has low sodium and they crave. It's a mechanism, the natural mechanism of the body to try to raise its sodium by making the patient be crave salt. I put that down, but if that's the case, also explains some things. For example, it can explain fatigue. If you have chronic hyponatremic, you can be fatigued. But again, I can connect it to something else. Among the causes, if it turns out to be hyponatremia, we'll delve into that area and discuss the causes. But quick things that come in mind, for example, this patient turns out to be that they truly have hyponatremia. One of the causes is um, I think deficiency. I think of the suprarenal gland, the hormone produced by the suprarenal gland. I think uh, uh, if you're deficient, I remember it later. If you're deficient in that hormone, then you can also have hyponatremia, and because also among the major organs, you can have the chronic fatigue. So yeah, in that area, but I'll delve into that if truly this patient turns out to be hyponatremic. Weight loss is a problem also on its own, but easy to explain this patient. We're not seeing any sign that this patient is inflamed in any sort of way, but they don't consume food as much because they have anorexia, they have nausea and loss of appetite. So let's turn to joint pain. So the joint pain that we are being told here, I can say it's a non-inflammatory joint pain because there is no swelling. Maybe in an exam, we'll be told whether there is other signs that we can see, and we didn't ask in history. But what we know, this will be a, a many joints involved, like the knees, two hips, two shoulders, but no small joints. Do I have a differential diagnosis here? So I think things like osteoarthritis are less likely. Usually don't start like this. They're usually monoarticular processes, mainly on the weight bearing joints, so less likely. And then how about other joint diseases like rheumatoid arthritis? Rheumatoid arthritis will start in the smaller joints, which is not the case here. So you remain with things. For me, if you start saying knees and you start saying hips and shoulders, something which comes up in my mind easily is something like, let's say, polymyalgia rheumatica. But is this the case? Maybe not, because polymyalgia rheumatica usually shouldn't involve the knees. Shouldn't involve the knees. And in polymyalgia rheumatica, there wouldn't be just pain. There also be weakness. Maybe we'll test in a exam. So I'll put in the back of my pocket this I can say something on hip and shoulders, but how about knees? How about knees? That I'll have to put a question mark. I don't think it's polymyalgia rheumatica. What is this? Let's see how the case evolve, and if I can come up with something else. So again, skin darkening, the rash, the way it is presented here, now we know this is an inside process. It's coming from inside. It's not something that came from outside, maybe, and affected the patient, causing the rash. It's something that developed inside the body of the patient. And after knowing that it's coming from inside, you can try to say which process causes the rash. There are a lot of processes that can cause the rash, like you can have autoimmune processes, and which turns out not the case here. the rash, for example, is not erythematous. We are not told of, Seba told us there is no hair loss, for example. If there was hair loss, you think on that category. So autoimmune processes, a rash of this kind with an autoimmune process, I don't think so. Other processes can come from inside and cause a rash, including infectious processes. Seba tried out to rule out some infectious processes like he told us of there is no penile rash. Yeah, very important. So apart from infectious processes, you have, I think, even malignant processes can cause rash. You've all heard of hematological malignancy, which can present with a rash, but still doesn't look like this. Again, another thing is an infiltrative process. You have things coming from inside of the body infiltrating into the skin and causes a rash. Too early for me to say here, but if one thing turns out here, for example, if I'll be very interested in trying to find out what's the sodium of this patient, and from there, much of the thing will start to fall into place. But I don't want to anchor at this moment because it will be short-sighted of me to say, okay, I think sodium is low. Now everything follows from there, and I can explain this rash. I can't, but at this moment. So let's see what we can pick on an exam, and when the exam comes, I'll be interested of the joints of the patient, the neuro exam of the patient. How does the rash look like? And yeah, from there we can go on with the discussion. Thank you very much, Seba.
Thank you, Dr. Joseph. I think that is an excellent clinical dissection. So moving on to the past medical history was unremarkable. In the physical examination part, general exam, so the patient was fully conscious, afebre, had a darkened face. We were able to see the prior picture before the onset of the illness and the current picture after the onset of the illness. So a patient was pale, was not jaundiced, cyanosed, nor dehydrated. There was not any angular stomatitis. So he had hyperpigmentations on the palms and soles, but there was not any palpable peripheral lymph nodes. There was no lower lymphedema. There was not any stigmatas for chronic liver disease. These were the vitals of the patient. So the supine blood pressure was 90/65. The erect blood pressure was 69/47. Pulse rate was 112. Respiratory rate was 17 beats per minute. Patient was saturating 98% in room air with normal core body temperature. RBG was normal, and anthropometric measurements were fairly preserved with a BMI of 22.8. So, Dr. Joseph, would you like to comment on this, or I should finish the whole systemic exam?
I think we should finish.
Okay. So in the cardiovascular system, patient had cold extremities. So the capillary refill was more than 2 seconds with pulse rate, which was 112 with regular, adequate volume, non-collapsing. It was synchronizing with other palpable peripheral pulses. There was not any raised jugular venous pressure, but there was an evident precordial hyperactivity. So the apex beat was fairly preserved. There was not any parasternal apical heaves. There was not any palpable thrill. The first and the second heart sounds were heard. There was no murmur, and there was not any pericardial friction rub. In the integumentary system exam, patient had normal hair color, texture, and distribution with no any alopecia. Patient had normal nail bed, no finger clubbing. There was normal oral mucosa. So what we were able to appreciate, these are the images of the patient, the face of the patient, together with the soles. So the same picture which is in the soles was almost corresponding the one which was in the palms. So we appreciated hyperpigmented diffuse brown macular discoloration. which were in the temporal and frontal aspect of the face and nose, spelling the nasolabial folds. So there was diffuse macules that involved the plantar surface of both feet. Some of them were coalescing to form patches. So the lesions, they were non-palpable, they were confluent and symmetrically distributed. So other systemic examinations were unremarkable in this patient.
Thank you very much, Seba. Yeah, so let me say this. I don't know anything regarding this case, but I'm trying to figure out what's happening, and that's what we call that also called clinical reasoning. So I'm trying to take different problems, dissect them with something which I don't know. I say this I don't know. Maybe let me put it aside, and what do I know? The thing which I know, does it add anything in trying to figure out what's happening? So thank you. The exam pretty much telling, except that we are told in the MSS, for example, musculoskeletal exam, there is like I think there is nothing. Patient say joint pain, but we are seeing nothing's happening, which increases my suspicion that this is an uninflammatory joint pain that the patient is having. But again, the neuro exam is also normal. So let's start with the positive that the patient had, and try to figure out and connect what was happening in the HPI that we were being told by Seba. So the first thing that we are seeing is that the rash we're being told, and what we're seeing the pictures explain the rash, and I've talked about the rash. I'll connect this rash later on in the process. But what I know now, this patient is pale, and when a patient is pale, it means when we do the CBC, we see a blood less than 8. It needs explanation. So from there, you can send other tests. So is it because they have anemia? That's why they had um, long-standing long-standing uh, long-standing fatigue. And the answer is highly possible unless there's something else. But other things start to come in. For example, when we do standing and lying flat blood pressures, we realize patient has orthostasis, a difference of more than 20 from standing from lying down to standing, which is the case here, 90/69 systolic or 10 diastolic also is in there. The pulse rate being 112 on its own, it's not helpful for now. But if you had the puzzlet when standing, puzzlet when lying, it can try to figure out why is the patient having orthostasis. So let me discuss orthostasis for some time here. So when you have orthostasis, it means your blood pressure fell down when you stood up, like you had a transient hypotension. So when you discuss the cause of orthostasis, you realize that most of them are the same causes of hypotension slash shock. So why would you have a low blood pressure on standing up? It's because in a normal physiology, when you stand up, your body performs some mechanisms to increase blood flow to the brain. So when that is not the case, the brain is so tricky. It's so selfish. It wants the blood. So if it realizes your body doesn't perform measures to give itself blood, it might cause you to like fall down, lie flat. And when you lie flat, it's like when you take a drum and lie it flat with half water. You lie it flat, water will flow to the top. So if you lie down, blood will flow to the top, and the brain will get its blood. And then you get blood, you wake up immediately. So that is orthostasis. So why that's the case? So the problem can be centered from the heart itself, from the blood vessels, or from the blood itself. So if you start in the heart, you can have, for example, an arrhythmia. But an arrhythmia wouldn't be predictive as this. It will be something which will be happening randomly. You are standing, it comes in, and you fall down. When we do orthostasis measures and we not find anything because at that moment there is no arrhythmia. In the blood itself, you can have a depleted volume, for example, in patients who are dehydrated or they have blood loss, they can have orthostasis. Blood vessels, the tone of the blood vessels is very important. So neurological diseases like any peripheral neuropathy which involves autonomic neurons will cause the orthostasis. So we are talking about Parkinson, for example, or long-standing diabetes mellitus with diabetes polyneuropathy, or any medication that can cause reduced tone of peripheral blood vessels, CCB, blood beta blockers, which this patient didn't have. Apart from that, yeah, so adrenal diseases, very important in patients like these who are having also stasis. If you have adrenal insufficiency, you also present with orthostasis. Yeah, so the reason why is that you have adrenal insufficiency, you don't have a lot of sodium. If you don't have a lot of sodium, you also volume down. If you're volume down, you end up with orthostasis. So be interested with the sodium of this patient also. Yeah, so from there, I think now cold extremities in a patient who is everything is fine like this. I'll be open to learn what will these turn out to be, and plus a cup refill that is more than two. I'll be open to learn what this translates to. I think I can say much on it right now. So can I figure out this rash right now, which I'm seeing? Uh, yes, I say this something from systemic. I mean, yes, something from inside. But what can it be? Hyperpigmented rashes. Now I'll use my experience, yeah, and not something that I'll be reasoning from the usual clinical reasoning ways. What I've seen a rash like this, I've seen I think in two patients. I once I saw it in a patient with B12 deficiency. I saw it at one point in B12 deficiency patient in a rash like this. And number two, I've seen it, I think, when I was a resident, I saw a patient whom we suspected, we didn't prove, we suspect they had adrenal disease, and we thought it was an adrenal TB at that moment. And yeah, a rash like this and then an adrenal disease is so well explained because there is a nice a pathophysiology in which the pituitary started to increase production of a pigmenting hormone, and then you have all sort of that. So these two, which I have seen, does them tally? B12, yes, maybe that's why patients have also anemia. But why would B12 deficiency cause joint pain and I mean nausea, loss of appetite, craving of salt? I I I think less likely. So how about again other thing of B12? We're not seeing them here, but it's not necessary to see, for example, neuropathy. You just test if you see something like this. Adrenal insufficiency also maybe adrenal insufficiency can cause orthostasis. Adrenal insufficiency can also cause hyponatremia. And as I said, I have never heard of the problem of salt craving. But if I use my reasoning, maybe it's the hyponatremia. Adrenal insufficiency can also explain it. But how would adrenal insufficiency explain the joint pain? Still, I can't figure that out properly. So right now, I'll be working with those and see in the exam what will come up. Seba, let's continue.
Thank you, Dr. Joseph. So switching on onto the part of investigations, full bed picture was done to this patient. This was the full bed picture. Then peripheral smear was done. And these were the iron studies. So serum vitamin B12 and folate were done. Sorry, I've not included vitamin B12, but the levels were normal together with the folate. The markers of inflammation, both acute and chronic phase reactants were done, the CRP and ESR. So serum ALDA was also done. Liver enzymes and synthetic functions were done. Renal function tests were done. A number of serologies were done to our patients: HIV serology, hepatitis B surface antigen, and hepatitis C antibody, together with the enterosyphilitic reactivity test, VDRL. Glycated hemoglobin was also done. So electrolytes were done. So I have readings which you are taking at two different points in time. And this was we went ahead and we did her hormonal profile to our patient, including the prolactin levels, the cortisol, which is an AM cortisol levels, the ACTH levels, the renin, aldosterone, together with the follicle stimulating hormone, luteinizing, and other thyroid hormones. Autoimmune markers were also done. So chest X-ray was done, then ECG, and echocardiography, and we also ended up doing an abdominopelvic contrasted CT scan. Yes, these were the investigations that were done, Dr. Joseph.
Yeah, thank you. That's a lot to dissect. I'll try. Um, yeah, Seba, can you mute your? Yeah, yeah. So I thought an exam patient would turn out to be like a HB of 8, but it's not the case. It's 11. Um, the peripheral smear said there is anemia. Maybe this patient baseline is something like 13, so 11. But I entertained B12 at one point. But what I'm seeing from this CBC, this is normal. This is normal. And if you
We have two readings, Dr. Joseph. So we have the first reading on 17th, then we have the second reading.
Oh, sorry, I didn't see that. Thank you very much for that. Yeah, so the first one, this like a week or a week point something apart. Yeah, yes, very, 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 very useful. Thank you. So the HB, as we are seeing it here, there is moderate anemia of 7 with an MCV of 90. That's a normal CTIC, a normal CTIC, a normal CTIC anemia. Yeah. So after finding out an anemia and you do your MCV, MCV, you can have only three things. You can have a low MCV, normal MCV, high MCV. A normal MCV like this, a normal CTIC anemia, differential diagnosis not much. One is hemolysis. Number two that I know, acute blood loss with before hemoconcentration sets in. You can have also normocytic anemia, but anemia of chronic illness also causes a normocytic anemia. And the last thing is anemia of CKD. Also turns out is normocytic anemia. So does this patient has hemolysis? Maybe because just 1 week from 11 to 7, maybe. So the next thing for me will be sending markers of hemolysis like indirect bilirubin, haptoglobin, LDH, and other markers hemolysis. Can I see the next? So what we know now is patient has normocytic moderate anemia, as the peripheral smear here shows. Next thing, yeah. So ferritin, very high levels of ferritin, like a ferritin above 1,000. So if you think your patient is inflamed and then they have anemia, ferritin won't be useful to tell whether it is a iron deficiency anemia. That's where you find the use of a TSAT, which is also normal. I would take a TSAT of less than 20% to say this iron deficiency anemia. So this is not iron deficiency anemia, but a ferritin of above 1,000, it needs explanation. It's not something that you can chill and say, okay, patient is inflamed. There are no much things that can cause hyperferritinemia of this sort. So, in theory, if someone puts a question and they put a ferritin like this, usually students would run and say something called, I think, HLH. HLH. So HLH usually present with a pancytopenia plus a fever, which are not the case in this patient. So we have to say we have to expect a very highly inflammatory disorder, long-standing in this patient. That's what I remember from my approach of extreme hyperferritinemia of above 1,000, like what we are seeing here. HLH means, for those of you maybe, hemophagocytic leuko. I don't know. There is a wrong form of it. You can Google and find out. But that's the differential diagnosis of hyperferritinemia and pancytopenia plus fever, which is not the case here. So let's proceed. So I'm putting aside this ferritin. I'm saying at the end of the day, the diagnosis have to explain this ferritin. If it doesn't, then I'll say I don't have a diagnosis. B12 for it being normal, again, puts me away. I was saying I was entertaining a diagnosis of B12 deficiency because of the rash that I've seen in my practice back. So I'm saying it's not the case. This is not the case, not B12 deficiency. Another test, Seba, yeah, Prasanias RCRP is high. So these two, with that hyperferritinemia, this is an inflammatory process. And let me tell you, inflammatory processes are usually three. You have an autoimmune disease, you have a chronic infectious process, and then you have a cancer. And it's not any cancer. It's either, if you say it's any cancer, maybe it's the cancer which is end stage, like you have a breast cancer and it's like at the final stage, mets everywhere. Now you can call it, and you have an inflammatory process from a solid organ cancer. But usually in a patient like this that we know there is no prior history of any solid cancer, something to be highly inflammatory like this. If you think of a cancer, usually it has to be a blood cancer, lymphoma, leukemia. Nothing else we have seen that shows in that category. Autoimmune processes, if you think of autoimmune processes, you start with the common ones, and they usually have the letter S, SLE, Sjogren, SLE, Sjogren, sarcoidosis, plus I think another S will be, it is 4S, forgot one. But again, is there anything that shows this patient might turn out to have one of the autoimmune processes? You realize no. How about infectious processes? So if you think of a chronic infectious process, hyper inflammation of this sort, you have to think of TB as long as you are living in this area. And of importance, if you think chronic infections in the patient, you have to consider the immune status of the patient. I think HIV was negative. Maybe there is other immune immune depressive diseases of other sorts. We are not being told in history, and patient seemed was normal until these symptoms started. So we can assume at this point this patient is has a normal immune status. So in a patient with a normal immune status, you think of a TB first, but you can also think of other chronic infections. Apart from TB, you also think of fungal infections, which can also happen in a patient who even is not immunocompromised. So yes, TB maybe, but TB can do anything, as you know. So we put aside this TB and say maybe it's the cause of everything, but still we haven't explained other things that the patient presented to us, and maybe we can connect of now what we're thinking of this TB. So for me, Seba, serum adder has no use. I usually don't want to entertain it because it has turned out like in many patients where I've seen they have a serum adder result, it takes me away of maybe taking the TB serious or not taking the TB serious. So like this serum adder, is it normal or not, Seba? The cutoff?
So it's within the normal range.
Yeah. So you see, it's within the moment. So at the moment, serum adder, when you are being told to say we are investigating TB, we are sending Siramada. But if you read the literature of Siramada, highly useful, especially from literatures from India, the US doesn't use it much because they don't have that much TB. Literatures from India have well put explanations about Siramada, about ADA. So the most use of Siramada comes from non-serum tests, like if you have an ascitic tap, if you have a pleuro tap, if you have a CSF, highly useful. But so this normal doesn't rule out that the possibility the patient has TB. So I'm keeping it, like I'm saying, it's not useful for me. I will still entertain what I was entertaining even before. Can I see another test, Seba? Another one? Yeah, another one. I think another time I saw, yes, here. So yeah, it turns out patient has a um, hyponatremia. Seba, do you mean this K is 7.1?
Yes, yes.
Okay. Oh, that's hard. Yeah, so the sodium of a hyponatremia, like a moderate hyponatremia, you can say maybe this was the one which was causing which was causing the salt craving of this patient. But how do I explain the potassium of 7.7 with a normal creatinine? I think the creatinine was normal, Seba, right?
Yes.
The creatinine was
Creatinine.
normal. Yeah. So because of time, I think we shouldn't delve much of here because if you have uh, if you have hyponatremia, the next thing is to tell whether it's true a true hyponatremia by sending serum osmolality, which maybe you don't do. But at the end of the day, a hyponatremia to cause symptom stay there for months. It has to be a true small hyponatremia. Differential diagnoses are many. Most common usually drugs people use Lasix at home. They have this hyponatremia, but there are other common things, including what Seba is already telling us here, the 1.5 cortisol AM, which is diagnostic. As long as it's below 3, it's diagnostic of adrenal insufficiency. So adrenal insufficiency explains hyponatremia. It's like one of the causes of hyponatremia, and explains other things now. The ACTH tries to tell us where is it coming from. Is it coming from the brain or a primary adrenal process? So the brain feels like there is no sodium, tries to increase the production of ACTH. ACTH goes up. ACTH is what I was trying to find, the pigmenting hormone. This also causes the melanocytes to show this pigment, what we have on the skin. So if it's this high, you expect the rash that the patient had. So everything starts falling into place. This patient has adrenal insufficiency, which explains hyponatremia and hyperkalemia. Usually not much, but it can be there. It can be there. For this, I think there is nothing as I'm seeing which is causing hyperkalemia. So it's the patient with primarily adrenal insufficiency. I think the next thing, Seba, is the imaging, right? Can we see the imaging? Nothing. Can you see the imaging? Yeah, not much. There was a CT. Yeah. So the purpose of doing the imaging, I think, is to figure out because the primary adrenal process, if you can see if there is a an adrenal process going on, like an adrenal tumor or something. So Seba, tell us. I'm not used to read this, but I see. I think on the left there has to be something, right? The adrenal
Yes.
was there is a finding, right?
So the report from the radiologist reported that there was not any significant abnormality and there was not any significant appreciated suprarenal mass. Yes.
Okay. Yeah, thank you. So if there is nothing found, then we know we have a primary pathology of the adrenal, which is not seen on the imaging. Now, what is that? Maybe that's a molecule which cannot be seen, an infiltrative process, or that's an infectious process which can be seen. In this patient, we've entertained much about TB. So let's say it's TB of the adrenal gland, which happens around here. So you also can't see anything because it's the granulomas that will be infiltrating there, causing the adrenal gland not to produce, and it will be a bilateral process because it will affect both the adrenal glands. So how will I diagnose this? Seba, are we at the end of the case, or you have any other? Because we are out of time.
Now, we are at the end of the case.
Should I come up with the diagnosis? Eh?
Yes, yes, doctor.
Yeah. So uh, difficult case, but I think at the end things for me start to fall into places. This patient came in with a long-standing fatigue, skin rash, joint pain, which can now be explained, explained except the joint pain, except the joint pain. But the fatigue and skin darkening, they can now be explained. Now the thing is, what's the cause? We have a primary pathology of the adrenal gland. Why is it happening? But we're also having that the patient is hyperferritinemic, plus they have an ESR CRP that high. They live in Tanzania. TB of the adrenal gland should be a number one differential diagnosis here. What else if you are wrong? So that's being a good doctor. What if you are wrong? How will you turn to another thing? So another is that you can have autoimmune processes that can target the endocrine organs, like if you have heard the diagnosis called MEN1, MEN2, like multiple endocrine neoplasia. But these won't just choose the adrenal. They also affect, like you have a pituitary, you can have a parathyroid gland, and then you can also have maybe pancreas or the adrenals. But that's not the case here. So for me, I will say, because I'm living in Tanzania, hyperinflamed patient with a primary pathology of adrenal, I'll say it's maybe number one, TB of the adrenal gland. And I don't know how will you diagnose this. I've completely forgotten how to diagnose it. Will you take a biopsy or what? At the end of the day, this patient needs adrenal. They need like not prednisone. I think they need dexamethasone for life. Like, they can't stay like this. Yeah. So Seba, I shouldn't waste most of your time. If I'm wrong, tell me. I think the diagnosis here will be TB of the adrenal gland. And maybe the joints. Why would the joints be painful? Maybe the TB of the joints. Yeah, that's my final diagnosis.
Yes, thank you, Dr. Joseph. I think that was a very excellent approach. So yes, so our final diagnosis was a primary adrenal insufficiency, which is the so-called Addison disease, presenting with adrenal crisis currently. So with the specific etiology, we have not pinpointed exactly what is the specific etiology, but as you have correctly said, we are in areas that are very endemic to tuberculosis. So TB adrenalitis is something which is on top of the list, then followed by a possibility of an autoimmune adrenalitis. More likely in this case, this is an isolated autoimmune adrenalitis. So modality for diagnosis of TB adrenalitis, as you have said, usually tissue biopsy is confirmatory. So there is a role of fine needle aspiration in this patient, but this was not done to this patient. So until up to this particular point in time, we did autoimmune adrenalitis markers, which is the antibody against 21 hydroxylase, that we are still waiting for the results of the investigations of 21 hydroxylase. So just a quick recap, Addison disease, it's a rare endocrine disorder which is characterized by adrenocortical insufficiency due to the destruction or dysfunction of the adrenal cortex. So usually it occurs when more than 90% of both the adrenal cortex are destroyed, resulting into significant deficiency of the glucocorticoid and the mineralocorticoid. So it's a rare disease. So the incidence is less than 1 per 100,000. And usually middle-aged individuals are the ones that are affected. It has a slight preponderance in women in comparison to male. So there are a number of etiologies that have been listed. So from literature has cited autoimmune adrenalitis to be the most common etiology, with isolated autoimmune adrenalitis being more common, being accounted about up to 40%, but a lot of literatures have cited autoimmune polyglandular syndrome, which the part of it usually consists of adrenal insufficiency. So we have three types of APS, which is the autoimmune polyglandular syndrome. It's a constellation of an autoimmune disease which usually affects the glandular organs like the parathyroid, the adrenal glands, together with other mucocutaneous glands. So it's common in type 1, in which the triad is hypoparathyroidism, chronic mucocutaneous candidiasis, and adrenal insufficiency. Then we also have type 2. So individuals will have thyroid disease, which commonly is Hashimoto thyroiditis, then or Graves, also type 1 diabetes mellitus, and vitiligo. So infections coming into a setting in which we are very endemic to tuberculosis, infection is one of the topmost causes of adult onset Addison disease, with TB being the leading cause, as you have correctly said, Dr. Joseph. So other infections which have also been listed to cause Addison disease is HIV, syphilis, and also disseminated fungal infections like the histoplasmosis and the so forth. Malignancies have also been listed. So commonly it's lung malignancy and breast malignancy. So it's usually advocated for patients who are having adult onset Addison disease. You have to look to rule out presence of occult malignancies. Usually the point of entry, you can start with chest x-ray, but if your clinical suspicion is very strong enough, you can go ahead by doing a very comprehensive imaging, which includes the contrasted CT scan of the chest. So other causes are things like bilateral adrenal hemorrhage. So there are a number of cases which have been reported in patients who use anticoagulants, specifically to be warfarin, who one of the rare side effects is that they ended up developing adrenal hemorrhage. Also infiltrative conditions like sarcoidosis, hemochromatosis, and amyloidosis have also been listed as potential etiologies of Addison disease. So this is just a quick recap of the HPA axis, the hypothalamic pituitary adrenal axis, which shows the interaction all the way from the hypothalamus by the corticotrophin releasing hormone, then later on followed by the subsequent action of the adrenocorticotrophic hormone, which is produced from the anterior pituitary gland, then up to the point in which they exert effect at the level of the adrenal gland, in which the adrenal glands, as the adrenal cortex usually produces the adrenal cortisol, but we also have the adrenal medulla, which produces adrenaline. But for this case, autoimmune adrenalitis usually only affects the cortex, but infections like TB adrenalitis have also been shown to affect even the adrenal medulla. So these are the patients that may present with significant derangement in their adrenaline levels. So keeping in mind that the adrenal gland is made up of the three layers, which we have the GFR, the glomerulosa fasciculata, and the reticularis, which is usually responsible for androgen production. So the effect of androgen in male is very small, because 90 to 95% of androgen in males is usually produced from the testosterone mediated, while only 5% is adrenal mediated. But that is opposite when it comes into female, in which about 50 up to 60% of the source of androgens in females is usually by the adrenal gland. So something also to keep in mind, aldosterone is also involved, but aldosterone is usually mediated by another axis apart from the HPA axis, which is the renin-angiotensin-aldosterone system. So usually this can help you to differentiate primary together with secondary adrenal insufficiency. So with primary adrenal insufficiency, usually the cortisol and aldosterone, all of them are affected, as in these patients. But in the case of secondary adrenal insufficiency, in which you have an impaired ACTH, usually the aldosterone is spared. So things like hypothyroidism may not be, things like hyponatremia usually, or hyperkalemia, they're not found in patients who are having secondary uh, Addison's disease. So this is just a summary of everything that we have encountered through in the primary adrenal insufficiency, just to highlight the most important striking feature. So our patient had hyperpigmentation in the face together with the palms and soles. So it has been postulated that the adrenocorticotrophic hormones, usually the gene that encodes for ACTH is the same gene that encodes for the melanocyte stimulating hormone. So there is usually a coincidental increase in the melanocyte stimulating hormone production from the pituitary, which usually triggers more melanin production by the melanocytes in the skin, leading into the hyperpigmentation in the skin and the mucosal surface that we have seen in our patient. And another important thing is the part of clinical symptoms like joint pain, anorexia, or weight loss, which have also been listed in the constellation of symptoms from adrenal insufficiency. So a lot of literatures have cited this to be common, but the exact mechanism why patients with primary adrenal insufficiency have things like muscle or joint pain has not been clearly isolated on that. So these are just a summary on the signs and symptoms. So just an easy way to arrange the signs and symptoms is basing on one particular hormone is affected. So we have symptoms due to low cortisol levels like hypotension, shock, hypoglycemia, fatigue, vomiting, decreased appetite, and abdominal pain. Symptoms due to low aldosterone levels, which is hyponatremia and hypokalemia, together with dehydration. And we have symptoms due to low androgen levels, which is predominantly common in females, basing on the reasons that I've said previously. So females, especially those who are premenopausal females, will tend to have irregular menstrual periods, decreased libido, and also pubic and axillary hairs. Other symptoms is usually based on the melanocorticotrophin releasing hormone leading into hyperpigmentation. This is just a simple approach on the diagnosis of adrenal insufficiency. So a clinical suspicion has to be there, which is followed by a screening test. After that, usually depending on the levels of plasma ACTH, plasma renin, and serum aldosterone, this can help us to classify if it's a primary adrenal insufficiency, which is usually individuals who have high ACTH due to the loss of negative feedback mechanism, leading into higher levels of cortisol, while low or normal cortisol almost always usually defines a secondary adrenal insufficiency. So another thing which is important here is levels of renin. So as I previously said, that renin usually it's usually affected when it occurs in the constellation of primary adrenal insufficiency, because this is the point at which the aldosterone hormone will be involved. So there will be loss of negative feedback, leading into higher renin levels. But for the part of secondary adrenal insufficiency, usually individuals will have normal renin levels and normal aldosterone levels. So autoantibodies usually important so that we can be able to isolate, is it autoimmune mediated Addison's disease, or is it non-autoimmune mediated? So this will be after you have looked for the autoantibodies. It's usually important to screen for the other important etiologies like chest X-ray, or to look for any occult search for malignancies like lung malignancies. Then for the part of secondary adrenal insufficiency, it's usually MRI pituitary may be done so that you can be able to isolate if there is any hypothalamic pituitary mass lesion also. So this is just a summary of the treatment of adrenal insufficiency. So a number of individuals will come when they've already developed adrenal crisis. So if the patient is having adrenal crisis, in which patients will be having an obvious clinical shock with significant dehydration, patients will need to have an effective cortisol replacement together with aldosterone and IV fluids to correct hypoglycemia, which is usually very common due to impaired gluconeogenesis in these patients, and also underlying electrolyte abnormalities are the ones that I've said. So the most common cause of death in this patient is usually hypotension, and something peculiar about the shock in patients with adrenal insufficiency is usually non-responsive to fluids. So that should also give a hint if you're having patients with such kind of complaints and the shock that they're having is non-responding to IV fluids. So for primary adrenal insufficiency, usually you need to replenish the glucocorticoid, in which you can use prednisolone or hydrocortisone, and also you need to replace the aldosterone, in which the drug of choice is fludroxone. Androgen replacement is only important for the selected number of individuals, specifically females, especially females who you have already kept them in glucocorticoid and also mineralocorticoid, but they've been having persistent symptoms like irregular menses, loss of libido. Then you can go ahead and prescribe the androgens in these females. So this is just a specific dose depending on what type of steroid you're using, which could be hydrocortisone or cortisone acetate or prednisolone. So another important thing is the sick day rule in patients who are having adrenal insufficiency. So patients with adrenal insufficiency, usually they may have increased demand. They may have some increase in demand when they tend to have an acute febrile illnesses or any kind of stress that can include either minor surgeries or major surgeries. So if an individual is having any kind of an illness, presenting with fever, home management can be done, but what is usually supposed to be done to the patient is to double the dose of hydrocortisone if usually the temperature is not more than 38, and also tripling is usually advocated when you have a high grade fever that is more than 39, and you can continue the increased dose until the illness resolves. So for individuals who are having adrenal Addison's disease and they cannot tolerate oral medications because they have had conditions like an acute gastroenteritis or trauma, usually it's advocated to change the route of an administration from oral route to intramuscular or IV route or even subcutaneous hydrocortisone. So for minor to moderate surgical stress or illness, usually administration of hydrocortisone 25 to 75 milligram. So the average is usually 50 milligram for 24 hours is usually done for for 2 days, and you usually proceed at least 1 day after the after the surgery has been done. If individuals are having a major surgery with general anesthesia, or they have encountered trauma or delivery or disease that usually requires an intensive care, administration of high dose hydrocortisone, which starts from 100 milligram, may be given to these individuals, and even continuation of an IV infusion of about 200 milligram for 24 hours is usually recommended. Yes, those were the teaching points, Dr. Joseph.
Thank you very much, Seba. This was a very nice case and highly educative. Uh, to tell you one thing, our minds very broken because I've presented a case here of an adrenal insufficiency to David at one point, which I took care. And now looking back, I realize, okay, as you're saying here, autoimmune adrenal should come first before you think anything else. And I think in TB over the adrenal, when you image, you I forgot this, you have to check, but you will see something. So if not seeing something, maybe that becomes less likely. And autoimmune adrenalitis, if it's an autoimmune process, can also explain maybe the anemia in this patient. This is an autoimmune hemolytic anemia, just a week from 11 to 7, plus that ferritin of 1,000. Maybe they can both be explained by an autoimmune hemolytic anemia. They can cause hyperferritinemia. It can cause ESR therapy to go up. It can also and but they say birds of the same feathers fly together. So autoimmune diseases tends to go up together. Autoimmune adrenalitis on one point, on one side, autoimmune hemolytic anemia on the other. Yeah, we are out of time, and I think we should close. So thank you, Seba, for taking your time and presenting this highly educative case. Thank you, the chat. I wasn't looking. Maybe if I did, I would have come up with autoimmune adenitis at the first differential diagnosis. Yeah.
So maybe just one more thing, Dr. Joseph. So markers for a possibility of autoimmune hemolytic anemia were explored. So all the Coombs test was negative in these patients, together with the bilirubin levels. The total and direct bilirubin levels were within the normal levels.
But we don't do a hapto, which is the number one test that we don't do in Tanzania, haptoglobin. I get you. I get your point. But what I'm saying is, if you had like haptoglobin, highly sensitive than anything else for hemolysis. So thank you very much. But when the tests come back, please let us know so that we can learn more if this is autoimmune. And maybe one thing against that is autoimmune is more common in the elderly. The patient I presented to David with thought of autoimmune, it was like 80 years old, 70-year-old female. Thank you.
Yeah. One point from Rajabu Twaha. So I think we had a typing errors. So the thyroid levels were within normal range. Yeah, so if you see in the lab parameters, you can see the TSH levels were elevated. This is the typing error,
Okay.
together with the T4. So they're all within normal range.
Thank you very much, everyone. See you next week.